Morning to one and all present here. Welcome to the Nuclear Week presentations and the celebration that we are having from the 7th to the 13th. I am Anutina and I am a staff nurse in Chest Hospital, and I have my colleague Mr. Sharda Beena also along with me. We will be answering your questions and giving you a brief description about what is our role, which is actually not just greeting the patient and putting in an IV line. It's just not that. So I'm going to just give you a brief outline about it. Role of a nuclear medicine nurse. The purpose of this communication today is basically to bring to your notice and to highlight the important role the nurses play in the nuclear department. Nurses spend a significant amount of time from the imaging, starting from taking history of the patient, reviewing the patient's preparation, medication, laboratory data, everything, and even performing a brief clinical examination on the patient. We also have an important role in assisting the nuclear medicine specialist, the physicians, the cardiologist, and also the patients in carrying out the procedures on a daily basis. We have a role in providing essential quality patient care and crucial in patients' life saving. The key roles. The key roles are assisting, as I've already mentioned, the cardiologist, the specialist, the physicians, and providing quality patient care, saving patients' life during an emergency situation, and also alleviating the anxiety and fear of the patient regarding the procedure. Now, on a daily basis, generally what are we doing in our department? We receive the patient from the reception and then we check the file. We see if the patient is slated for that same kind of study from our patient list. We check the files and find out if the test that is mentioned in that paper is correlating with the disease condition that the patient is actually presenting to us with. We greet and ask the patient a brief history, and a quick physical assessment of the patient is also done. We check the height and weight of the patient, like my colleague Mr. Muhammad has already mentioned. Why do we need to do that? We have already mentioned that. Because they are preparing the dose with the international standards. And check the vital signs. In the meantime, when the patient, we are talking to the patient, we find any discrepancies or any confusion. Like supposing the patient says, I cannot lift up my right hand or my left hand, or I cannot lie down under the camera supine. All these are things that I will be dealing a few seconds later. We will be asking the help of our nuclear medicine specialist as well as the physicians. Okay? And that is how we work as a team along with them, as the situation demands, of course. For our regular easy work, we actually formed a checklist to determine the patients generally. And since we are working in a tertiary level specialty hospital, especially for the cardiology, this is done for the stress patients for myocardial perfusion. We have prepared it. It's not like, so I'm just going to give you a small overlook on that. I would ask a patient, are you fasting today? How are you feeling today? Some patients say, I'm feeling very tired, I'm feeling very sick, I'm not really into the mood of this test today. So we would ask this patient all this. Do you have any chest pain? Are you on any medications, and have you taken your medications today? Did you take any medications to relieve your chest pain in the last 48 to 72 hours? Because that's going to make a difference in our imaging and in our study. If the patient has got chest pain, this actually means the patient had angina, and the patient with an angina cannot do a stress test. And do you have bronchial asthma? Do you take any inhalers? Because this is a major contraindication to one of our study, the stress study, that is Posantin. And drugs like Tenormin, Concord, Lopressa, these are basically the beta blocker group of drugs, which is a contraindication for treadmill and dobutamine. Were you admitted any hospital recently, and why so? Then we would know the general condition of the patient, if any other problems the patient faced recently. An important question is, did you take any coffee, cola, tea in the last 24 hours? That is, the caffeine and the nicotine intake actually causes a big, the reporting or the imaging will be totally disrupted if the patient takes all these. Lying under the camera supine for 15 minutes without coughing, motionless and with normal breathing, could you do that? Because motion abnormalities can be caused when the patient moves under the camera while coughing and if the patient moves under the camera. Normal breathing is required. You don't have to take deep breath during the 15 minutes of scan. Can you lift up your left arm above your head during the scan? Left arm, why? Because most of the patients would say, sister, my left arm has got some problem, I can lift up my right arm. Sorry, I don't need your right arm to be lifted up because your heart is on your left side. Okay, so I would be giving that answer unless of course I know the patient is a dextrocardio patient. Coming to the various stress modalities which we do on a regular basis is exercise stress, which is again, as the name suggests, treadmill. Pasantin, also known as diaprodamol, and dobutamine stress. This is cardiac I'm talking about right now. Exercise stress, as it is clearly evident. We do this for patients who are able to walk for 8 to 10 minutes on the treadmill. If the patient is physically incompatible to walk on that, if the patient has got any surgeries, we are not going to ask the patient, can you, even if the request says exercise. We can see if the patient is walking on the crutches. He's not going to walk on the treadmill. So apart from those contraindications like beta blockers, did you take your beta blockers? If the patient has taken his beta blockers and I need the patient to achieve, the cardiologist, I'm working along with the cardiologist, so I would also have to look into this. We would want the patient to achieve a target heart rate. And what is this target heart rate? Target heart rate is 220 minus the patient's age. So if the patient's heart is well blocked by a beta blocker, I don't think it's a good idea making the patient exert for a treadmill. Okay? And again, angina. Like I said, stress is not a good option at that point. Uncontrolled, unstable angina if he has, uncontrolled hypertension, and exercise is going to increase his blood pressure, which is going to give us false readings. Any hypertrophic obstructive cardiomyopathy, left ventricular hypertrophy, left bundle branch block, and if the patient's heart rate, like vital signs, I would be checking his heart rate also. Evaluation of the patient, like within 3 days, within 72 hours of MI, we will not be doing this test. And angioplasty and stenting. This is a controversial issue because some doctors would say, after the stenting, I can even do it the next day, or a nuclear scan. But some doctors would say 2 weeks is actually required for the collaterals to be established and revascularization assessment can be done only in that given period of time. That is why. It all depends on the cardiologist also. And patients taking oral diaprodamol, because in diaprodamol, I'm sorry, I think I skipped a slide. Okay, I finished with the treadmill and this is a Pasantin. Pasantin is the first kind of pharmacological drug, and that is done for patients who cannot walk and the patients who do not have bronchial asthma. Because Pasantin is, what is a Pasantin doing? It will aggravate the bronchial asthma. So we do not do for patients with the history of bronchial asthma or ongoing asthma. And then, like I said, the same thing, angina and the stenting, all these are a standing kind of protocol for all the 3 kind of tests. And if the patient is taking oral diaprodamol, we can give IV diaprodamol test provided he stops for 48 to 72 hours. Already a vasodilated patient cannot undergo a immediate vasodilation test. This is a pharmacological vasodilatation. Greater than first degree heart block, 6 sinus syndrome, patients with low BP, Pasantin has got an effect of causing hypotension. Vasodilatation causes hypotension. So a low BP patient we cannot do. Use of xanthines, aminophylins and caffeines in the last 12 hours is a contraindication, and severe sinus brady. This also reduces the heart rate. I think the Pasantin is clear because I just started off without ending off with treadmill. Okay. Dobutamine. Coming to dobutamine, it is another kind of cardiology stress This is done for patients who come to us with ongoing your bronchial asthma, and the patients with again beta blockers, we will not do this. Here again the target heart rate is a issue. This causes pharmacological vasodilator stressing, and this actually causes a patient to go into tachycardias and ectopics. Recent MI, ventricular tachycardia, angina, these are contraindications again. Uncontrolled hypertension, as you all know, dobutamine is a inotropic drug which is causing high BP. So we will not be doing uncontrolled hypertensive patients and on beta blockers. Stress test ends with a rest test for mostly 99.9% of the patients, except of course if the patient has got total normal coronaries in the stress test viewing. In this, I would ask a patient if the patient is fasting. Patient has to come in a fasting state. Then as he enters into the injection room, I would be putting in an IV cannula for the radioactive tracer to be injected. After about 15 to 20 minutes of administration of the radioactivity, he is given breakfast and his regular medications. And after an hour of injection, the patient is taken under the gamma camera for scanning. There I will be preparing the patient under the camera. Other procedures, we do these procedures in our department, like treadmill persantin dobutamine, as I have mentioned, cardiac viability. In the viability, this is basically to see if the myocardium is viable for various studies like CABG, or if there is low EF. All these are the indications. In this, the role of a nuclear medicine nurse is the patient comes to you and we would be checking the BP of the patient in front of the nuclear physician, and he would check the BP, and if it is more than 130/80, or if he says please give a GTN, we would be giving the patient a GTN, sublingual. And after giving that GTN, we would wait for the GTN to be totally dissolved, and then in the meantime I would be putting in an IV cannula. Why? Because GTN causes hypertension again. So the patient can go into hypertension, and in case of such an emergency, I would need an IV line for fluid administration. Okay, so IV line is established as when the patient is given a GTN. I would ask the patient to wait for 15 to 20 minutes, as much as a GTN takes to dissolve, and then I would again call in the patient. The the nuclear physician comes in, he injects a dose, and within 10 to 15 minutes we will be preparing the patient under the camera. And the first imaging will be within 10 to 15 minutes, and that would be gated. Gated means with the ECG leads on. Then after 3 to 4 hours the second imaging, and 24 hours the third imaging. Those two would be non-gated without the ECG monitoring. Okay. Lung perfusion and ventilation. This is to see the perfusion of the lung capacity and the perfusion of the lung. If the patient has got any tumor resection before all that, this is like a study to understand the lung capacity. And ventilation, how good is the lung ventilation capacity and the blood flow to it. In perfusion, in all these, the weight and height of the patient needs to be checked. Okay. In the lung perfusion, we would ask the patient to come with a recent X-ray, because if there is changes in the lung, we would be able to notice in that. Within 24 hours, we need a recent X-ray. Then we ask the patient, I establish an IV line, and then under the camera, the patient will be injected. The doctor will be in the gamma camera room, and the patient is asked to take a deep breath at the time of injection. And we would be taking, the nuclear medicine specialist will be taking various views of the lung. Okay. And the ventilation, coming to the ventilation, like Mr. Mohammed has already shown you, in the ventilation the patient will be asked to inhale the radioactive, and after that is the scanning. Gated blood pool, in that there is no need of an IV line in the ventilation part of it. Gated blood pool, in the gated blood pool, again the patient is coming and the patient needs to be given put in an IV line, and after the IV line is put in on one arm, on the other arm we inject PYP, pyrogenated phosphate we inject, and we wait for 15 to 20 minutes, and at the 20th minute, around that 15 to 20 minutes, we would call the doctor in to put in the radio tracer, and the patient has to be taken in another 15 to 20 minutes under the camera. Okay, and in that the gated blood pool study is done by the nuclear medicine specialist. Bone scan, there are two types of it, like static, which is like under the camera he is injected. Again, under the camera the patient is prepared and we call the doctor and the doctor injects through the IV line. And delayed, we inject the patient and ask the patient to return back after 3 hours. That is a dynamic imaging that we will see. Gallium scan, renal scan, thyroid scan, gastroesophageal reflux scan, liver scan. These are some of the other scans. Renal scan, in renal scan there are two types of it, that is with Lasix and without Lasix. And even after that we have the captopril study also. In the captopril study, the patient comes to you with renovascular hypertension. So we give the patient Capoten 1 hour prior to the imaging, and every 15 minutes after giving the Capoten, as we all know Capoten is an AC inhibitor, antihypertensive. So hypotension is another complication. 15 minutes interval for 1 hour we will be checking his BP. After that we take the patient under the camera. Under the camera the image is obtained. After that the nuclear physician is there. The nuclear physician would ask us to give a Lasix or not, to find out if there is any obstruction or not. And Lasix is given, imaging is done. Okay. Now this patient has to be keenly observed, because once the patient is out of the scan room, captopril and Lasix, the stress, the imaging, everything can cause major hypotension for this patient. Thyroid scan, again, thyroid scan also include scanning and uptake study. Uptake study, like we have already seen, the probe is actually put into the patient's thyroid, and she or he is given a capsule or a gas inhalation on one day, and after 24 hours maybe the patient can come to obtain images the next day. And also he can also be given an IV through an IV cannula in radio tracer, and then the scanning is done. Uptake is different from scanning. On the uptake day, scanning is not done. Only the spectrum reading is being done on the same day. From the time the patient comes into the department to the patient leaves, we have to anticipate for emergencies. During ECG monitoring, with or without ECG monitoring, patient after stress study will be sitting and having his food. We can expect emergencies like SVT, ectopics, AF, hypertension, anything. For that, the various kind of drugs we use are as the situation demands. Post-test. Post-test, what is the education and what is our role? Patient is given instruction that please drink 1 to 2 glasses of water after your stress or after your exam. High fatty breakfast is given to the patient, including cocoa milk, because a high fatty breakfast aids in the better imaging. And we provide the patient with the food. If the patient is diabetic, we instruct the patient not to take any anti-diabetic treatment in the morning, because the patient is fasting, patient has undergone stress, patient may or may not eat the whole tray that we provide. So hypoglycemia could be a complication. And most of the patients are diabetic patients. If the patient is sick, we keep the patient under observation in the recovery room. Now, after the stress, we have the imaging. The test and the imaging interval varies for different patients at different times. Type of test done. For Pasantin, it is about 1 hour post-test. For Dobutamine, it is about 1.5 hours. For a treadmill, it's just 45 minutes. Apart from that, type of test done, weight of the patient. Obese patient, we delay a little more. Mobility of the patient. Immobile patients, we delay it maybe another 10 more minutes than scheduled time. Any EKG changes during the stress study, if the cardiologist notices any positive stress study, we will not wait for 45 to 1 hour. We might take the patient even at half an hour. And generally, it is between 40 minutes to 1.5 hours. Looking out and anticipating, like I mentioned, is for emergencies like seizure, cardiac arrest, pulmonary edema, hypertension, hypoglycemia, and calling out for help to correct all these happens on a regular basis in our department, because patients are not coming as on an OPD basis just for a checkup. These are patients coming with multiple CATs, post-CABG, lots of other complications like ectopics, AF. So these patients are problematic patients. Anticipation, quick action is the key to save life, and resuscitation without loss of time. This is our role in the nuclear medicine department. Hope I have given you a brief outlook to it. Thank you. Any questions?